not the same. IBS stands for irritable bowel syndrome, whereas IBD is inflammatory bowel disease. So, in inflammatory bowel disease, the disease is of chronic duration and there is an inflammation in the bowel. So, basically, there are two types of diseases in IBD. IBD is a broad umbrella term which covers two diseases, which are ulcerative colitis and Crohn's disease. Ulcerative colitis is a disease which mainly involves large bowel or large intestine, which is colon and rectum. Whereas Crohn's disease, it involves mainly small intestine and or large intestine as well. So, coming to the main differences between these two diseases, ulcerative colitis and Crohn's disease. Usually, the age of presentation, Crohn's disease patients, they usually tend to present at a younger age, whereas ulcerative colitis patients, they are little older in age. And ulcerative colitis is a chronic inflammation of the large intestine, which is colon and rectum. Uh, Here, the disease involves mainly the superficial layers of the large intestine, where there is a formation of ulcers or inflammation in the large intestine. Whereas in Crohn's disease, the inflammation is not superficial. It involves the deeper layers of the intestine. And the main involvement is with the small bowel or small intestine, which is usually up to a length of 6 meters. So let us discuss the clinical features or how a patient presents in IBD. Coming to the clinical features, the usual presentation in a patient with IBD is the patient typically gives history of long duration, as in the symptoms are present for weeks to months, and the main symptom predominantly is bloody diarrhea. So the patient usually complains of increased frequency of stools or loose stools, most often mixed with blood, or passage of frank blood per rectum is also possible in some scenarios. Apart from bloody diarrhea or increased stools, there is pain abdomen as well. The pain abdomen, in addition to pain abdomen, usually there is weight loss or easy fatigability. Because the disease is of chronic duration, patients usually present to a gastroenterologist with history of weight loss and easy fatigability. So these are the broad clinical features with which patient of IBD presents to a gastroenterologist. So after clinical features, after patient coming to a gastroenterologist, how do we come to a conclusion that the patient is suffering from IBD? IBD usually is a disease of westernized world in the previous or maybe we can say for the last 2-3 decades, the incidence of IBD has increased in India as well. Probably, if you come into the details or uh, if you come if you speak about the etiological aspects, usually why IBD occurs, it is because of some phenomenon called immune dysregulation, wherein the immunity or the immune system, which usually acts against an invading virus or bacteria, it tends to act on our own gut or bowel layers, causing inflammation and ulcers. So, the main cause, which is discussed in the recent past regarding the incidence of IBD in India, is because of mainly westernization or change in the lifestyle or increase in the infections, which is somehow triggering an immune reaction in the intestine and causing inflammation or ulcers in the intestine. So, this is the brief etiological aspects of IBD. Then coming to diagnosis, what are all the modalities usually we as a gastroenterologist use to diagnose a patient with the symptoms of IBD, which are bloody diarrhea, pain abdomen, weight loss, and easy fatigability. Usually, first we tend to order some blood investigations, which are blood count, CBP, or ESR and CRP levels, and then we usually tend to order stool or analysis. Sometimes a test called fecal calprotectin levels, they are ordered in order to look whether the intestinal epithelium shows features of inflammation or not. Usually, typically in a patient with IBD, the fecal calprotectin levels are elevated. In addition to this blood and fecal tests, we also order or we also perform a test called colonoscopy and or endoscopy to diagnose and to take suspicious biopsy specimens. The diagnosis of IBD is usually after a microscopic examination by a histopathologist. So whenever we perform a test called colonoscopy, in which usually using a long slender tube with a video assisted camera, we pass the scope through the anal canal and we check the large intestine. And in IBD or ulcerative colitis, typically we find redness or patches in the intestine and or ulcer formation. So from these areas, we usually take biopsy specimens and we order for a histopathological examination by pathologist. So after confirmation uh, from a pathological examination, then the diagnosis of IBD is established. So after coming to a conclusion that patient has features of IBD, then comes mainly the management. So here in the management perspective, we must understand one major important thing when it comes to IBD. So the patients, they need to realize that IBD is not a disease of short duration. Most of the patients suffering with IBD or inflammatory bowel disease, they need to be explained carefully that the disease is going to be present in usually for a longer duration, months to years, and sometimes it can be a lifelong disease as well. But that doesn't mean it cannot be controlled or it cannot be kept under check. There are very good medications which are available for us to treat effectively the features of IBD. However, the patient needs to understand that the disease is going to be there for a long term, and patients, most importantly, they require long term follow up with a gastroenterologist in order to identify possible complications or drug related side effects, or in order to effectively manage his nutritional status. So, the importance of long term follow up lies with the fact that in IBD patients, usually because of the chronic inflammation, there are few complications which can arise. The complications can arise because of long term nutritional depletion, and the patients can have features of malnutrition, or patients can easily develop infections, or patients can develop other disease related complications. So when it comes to complications, we must know few broad complications which can occur in a patient with IBD. When it comes to Crohn's disease, because usually the disease is uh, localized to small bowel mainly. Usually, the small intestine is a long structure which is up to 6 meters in length. So, because of the chronicity or long duration of the disease, the patient can develop fibrotic strictures, as in the intestinal wall gets thickened and becomes narrowed over a period of time. Such patients develop increase in their symptoms, as in patients typically have features of obstruction, as in pain and vomitings, or sometimes there can be increase in the uh, pain levels as well. So, when it comes to ulcerative colitis, patients can present with complications like in a long-term patient, as in patient with duration of disease for more than 10 years or so, he can develop colorectal carcinoma or colorectal cancer. So the mainly the cancer risk in patient with ulcerative colitis, it is mainly dependent on two things. One is the duration of the disease. Any patient who has inflammatory bowel disease or IBD for more than 10 years is at risk for development of colon cancer unless we perform thorough screening or unless the disease is under active remission, the risk of cancer can be high. So this is the reason why usually when a patient present to us initially, we usually ask the patient to not to miss any follow-ups and adhere to our treatment and not to stop medications inadvertently. That is the reason because we need to monitor patient's response. Here the response is typically called remission. So what is remission? Whenever patients present to us with the features of IBD in clinical scenario as well as laboratory features. So once we start on treatment, so the patient usually improves, but this improvement will take usually few weeks to months to happen. So once the patient is typically all right, performing well, there is a reduction in the number of stools or there is a reduction in the bleeding happening through rectum. So usually patients, what mistake usually a patient does is, usually the patient stops medication without gastroenterologist advice. So this is the main reason why long-term follow-up is important in a patient with IBD because even if patient attains remission, there are few criteria where once the patient is in remission, we tend to usually uh, put the patient on maintenance treatment for a long term. The reason is because, as we discussed already, IBD is a disease of dysregulated immunity or immune dysregulation. So, because the long-term treatment it helps in keeping the immunity under check. The immune cells acting against our own gut epithelium, it is kept under check with the maintenance therapy. What we use usually in a patient with IBD. So, when it comes to treatment, what are all the different modalities of treatment we have for an IBD patient? Usually, when it comes to medical management, the drugs we classify into because IBD is an inflammatory disease of chronic duration. We usually use drugs called anti-inflammatory drugs, which can be in initial stages to attain remission. Which we use steroids initially to reduce the inflammation or keep the immunity under check so that the patient typically attains remission where the patient's symptoms will get reduced. The bowel wall inflammation or the intestinal inflammation, ulcers, they get healed over a period of time, which is usually few weeks to months. So once the patient attains remission, then we put the patient on maintenance therapy. So in addition to steroids for using remission, we also use other drugs which are 5-amino salicylic acid derivatives, usually mesalamine. So these drugs they keep the inflammation under check and helps in healing of the mucosa or intestinal lesions or ulcers. So once the patient is uh, well, patient's symptoms they have subsided, then the patient is shifted to maintenance regimen. So what in maintenance regimen usually we use drugs called immunomodulators like azathioprine. So these immunomodulators they help in using or they help in improving the symptoms as well as they help in keeping the inflammation or immunity under check so that the patient doesn't present with the relapse or the patient doesn't have any flare of the disease in the future. Usually flares or increase in the symptoms again after achieving the remission, usually they happen because of infective reasons. So that is why usually when we treat, the main advice what we give to patient is in addition to strict adherence to our drugs or medical management, nutrition also plays a very important role. Nutrition, as in high protein diet, consumption of plenty of fresh fruits, vegetables, and fiber rich food. These nutritional advices, they help in maintenance of healthy gut, as well as they also prevent patient from having repeated gut infections, because patient, if they have repeated gut infections, then the patient can have flares or increase in the symptoms of IBD. So the more the flares, the worse is the prognosis in the future. So coming back to our modalities of treatment, once we have immunomodulators, patient is doing well. Usually, patient is asked to monitor his symptoms, as well as his monitor his blood counts serially, because some drug-related complications can arise with the use of immunomodulators. But however, they are not so severe. All it requires is proper monitoring of the blood levels periodically, and proper guidance by the treating gastroenterologist. So that is why I am re-emphasizing on the fact that IBD patients require frequent follow-ups and chronic monitoring and chronic follow-up with the gastroenterologist. And then coming to other modalities of treatment, what we have, we must know about the drugs called biologic agents, which are usually an injectable agents. It can be given intravenous or subcutaneous routes. So these biological agents are usually tools what we use, or medicines what we use in a patient who typically doesn't respond well with these immunomodulators or anti-inflammatory agents. So once the patient is under remission, the patient is asked to follow up typically, and periodic assessment, and whenever required we also perform colonoscopy again to check the improvement in the intestinal inflammation. The ulcers which were typically present at the time of diagnosis, they usually resolve, and the intestine again, the epithelium regenerates, the superficial layers, they all become normal. That's how the diarrhea, that's how the pain and the bleeding, they subside as a part of healing. Coming to other modalities of diagnosis, we discussed about colonoscopy in IBD. There are other modalities as well. Uh, when it comes to Crohn's disease, usually we use something called enteroscopy. Enteroscopy is nothing but a test we use with the use of a specialized endoscope, which can be either a balloon enteroscopy or a power spirus enteroscopy. So the advantages of using enteroscope is to reach the deeper layers of the intestine or deeper small intestine, because typically when we perform a upper GI endoscopy or normal endoscopy, we usually reach up to distal part of the duodenum, or which is the initial part of the small intestine. Whereas with enteroscopy, it can be either balloon enteroscopy or it can be power spirus enteroscopy, which is the latest gadget what we have in enteroscopy. So with this, we can enter the uh, deeper parts of the small intestine. We can almost reach the distal part of the small intestine, which is a terminal ileum. So the advantage being that we can detect the missed lesions. Uh, Sometimes radiologically they can be missed. So we have a direct access to the intestinal lumen with the usage of endoscopy. And apart from that, we can also take biopsies, which help in making the diagnosis of inflammatory bowel disease. And also there are some therapeutic, there are some procedures with therapeutic intent. So whenever patients, especially with Crohn's disease patients, over a long duration of time, if they develop narrowing or thickening and narrowed bowel lumen, which is called a stricture. If it is a localized stricture, which is up to a few millimeters to few centimeters, or a focal stricture, sometimes these focal strictures can be dilated by our enteroscopy. We use some gadgets which are usually balloons. We tend to pass the balloon through the narrowed part and inflate, and that's how the narrowed part gets dilated. So here, with the use of these enteroscopic methods, what we are achieving is we are for a localized disease or for a focal narrowing of the intestine, we are able to treat endoscopically. We are avoiding patient. We are avoiding a major surgery for the patient. So that's how the morbidity and long-term mortality it is improved with the use of this less invasive techniques. But however, in a in a widespread disease, there are indications for surgery as well. So when it comes to treatment in IBD, we have known that usually IBD responds well with uh, medical management. Whatever drugs we use, which are usually uh, aminosalicylates, steroids, immunomodulators, or sometimes in an unresponsive case, biologic agents. Uh, these drugs usually they control the disease well, they improve the symptoms of the patient well. But however, there are unfortunate cases where, in spite of the best medical management we give, the disease per se, the disease, the nature of the disease per se is relentlessly progressive, as in the inflammation is uh, continuously increasing or progressing, causing widespread damage to the intestine. So that's when where we resort to surgical treatment in patients of IBD. So when it comes to surgical management, we must know few procedures what we usually do as a part of IBD management. For a patient with extensive inflammation of the colon and rectum in ulcerative colitis, widespread disease, usually proctocolectomy is done, which is removal of the entire colon, and it is reconstructed either by permanent stoma through the abdominal wall, or sometimes, if possible, the anal ilioanal anastomosis. I mean, they join the distal part of the small intestine to the most distal part of the large bowel. So this is the procedure usually what surgeons do in uh, progressive or severe ulcerative colitis not responding to medical management. However, in Crohn's disease patients also, sometimes there can be need for surgery, as in whenever patients develop extensive strictures which involve multiple areas in a small intestine, then the affected small intestine is removed and the normal intestines are joined again. So this is a segmental resection of the bowel which the surgeons perform for strictures of the small intestine. So these are the broad treatment modalities what we have for management of IBD. So before ending my talk on IBD, I would like to reiterate on few points, which are first, IBD is different from IBS. Both are not the same. IBD is a disease of chronic duration, and IBD involves both small and large intestine as well. And IBD management involves long-term follow-up. IBD management also involves a multidisciplinary approach. It is not just a gastroenterologist who treats IBD. Sometimes the gastroenterologist also tend to take help from the dietitian colleagues as well, because nutrition also plays a predominant role in the management of IBD. And whenever necessary, surgeon comes to rescue of the patient, and surgeon has a role in IBD as well. And the other point which I would like to stress upon is usage of enteroscopy. Enteroscopy is a novel technique, and with the advent of a recent tool, which is a power spirus enteroscopy, which is a motorized enteroscope, the uh, within a short period of time, the deeper layers of or the deeper parts of the small intestines are reached, and the focal narrowing or the focal diseased areas, they can be attended by enteroscopy, which can prevent surgery sometimes. So the patient, the last point for today is the patient has to be under follow for long term. If necessary, the patient has to take medicines for lifelong, because effective control of IBD helps in maintaining patient's health in a long-term basis, and also it prevents the risk of colorectal cancer. I would like to conclude my talk on IBD here, and I'm ready to take questions if there are any. So I hope there are no questions. Are there any questions?